Ladies and gentlemen, a very good morning to you. I really thank you very much for this opportunity, which I think will be a great engagement with the government and the Department of Health. I'm required to speak about the National Health Insurance, which many of you heard from the first time, not from us, but from those who did not like it, by what was called a leaked document, as it happens quite often. So the manner in which National Health Insurance was introduced was a little bit negative, because it was not us who were saying, this is what we want to give to the nation, but it was other people talking on our behalf. So today you have got me here. It's not a leaked document that I'm going to read. It's what the government wants to do. First of all, I want you to understand that we've got the driving force behind us. And the driving force behind us is the fact that health is a public good. That is our assertion. Unfortunately, anybody who doesn't agree with that assertion will never agree with us on anything from now onwards. Health is a public good. And we are forever guided by the declaration of the World Organization, which was made more than 30 years ago in the small town of Alma-Ata in the then former Soviet Union. The Alma-Ata Declaration that states that health is not just the absence of disease or infirmity, but is a state of good physical, mental, and social well-being. And that the attainment of the highest standard of health is the most important worldwide social goal, whose realization needs action from other sectors, social and economic, in addition to the health sector. That is the Alma-Ata Declaration. And it ended with a slogan of health for all by the year 2000. 1978 then seemed like millennia away from the year 2000. The irony of it all is that the year 2000 came and went, and there was no health for all. In fact, there was even a reversal of gain. Certainly, in our country, there were reversals in terms of health for all the people, the citizens of the country. I was told that it will be difficult to show slides, but I would like to show the first slide just to demonstrate what I'm talking about, if possible. If somebody can project the slide there onto the screen. Yes, that is a report done by the Lancet, a very prestigious British medical journal, which shows that South Africa is going through a quadruple burden of diseases. Many countries, or almost all countries, are going through a double burden of diseases. That means communicable diseases as well as non-communicable diseases. But in South Africa, it's a quadruple burden. First and foremost, the burden of HIV and AIDS and tuberculosis, which have sort of got out of control. Secondly, the issue of maternal, newborn and child health, which have gone worse in the past decade. Thirdly, the issues of non-communicable diseases, diseases of the lifestyle, which I describe as 4x4. We describe them as 4x4 because they are broadly in four main categories of chronic heart disease and hypertension, of chronic lung diseases, of diabetic mellitus and a few metabolic diseases, and of the cancers. And the other four is because there are four risk factors denoting our lifestyle: tobacco, alcohol, diet. I don't know what is in front of you today. It might fall in that category. Hopefully not. And a lack of exercise. That's non-communicable diseases. And the last is violence and injury, which I don't have to lecture South Africans about. For this reason, we thought if we are to deal with this quadruple burden of diseases, we need certain outcomes from the healthcare system. And our outcome is a long and healthy life for all South Africans. In order to achieve it, we came up with 4 outputs. That firstly, we need to increase life expectancy. Life expectancy in South Africa has taken a knock, especially because of this quadruple burden of diseases. So much that it is said that by 2015 or so, life expectancy will be where it was 50 years ago, meaning by 1955, I mean to say, meaning that we have moved back more than 50 years. Our second output is decreasing maternal and child mortality. And the third one is combating HIV and AIDS and decreasing the burden of disease from tuberculosis. The last one, which seems to be interest everybody, especially people who are here, is the strengthening of the healthcare system effectiveness. The healthcare system in South Africa is not effective at all, because if it was, we wouldn't have suffered this quadruple burden of disease. And we want to strengthen it. And we have chosen 5 programs to strengthen the healthcare system. The first one being infrastructure, the second one being human resource planning, development and management, the third one being quality of healthcare services, and the fourth, the re-engineering of the primary healthcare system in South Africa, and the last, the cost of healthcare. That is where the gist of NHI lies, the cost of healthcare, which many people are very much interested about. Because of the quadruple burden of disease, death has literally doubled in South Africa within a period of 9 years. If you go to the Home Affairs Death Register in 1997, it registered total number of deaths as 317,000. If you visit the same register in 2006, it registered the total number of deaths to 619,000, meaning that we have doubled death in a period of 3 months, of 9 years, because of this quadruple burden of disease. Now, before moving over to the issue of NHI itself, I also want to project the following slides to demonstrate what I'm talking about. Can somebody project the slides for me, please? Leave that one, go continue. I don't know who's projecting the slides. Yes. That which you see there is the map of the world as you know it. But if you do a computerized version of the map of the world with the distribution of HIV/AIDS, that's what the world looks like. Almost all continents disappear and Africa bulges. And you need doctors and nurses to deal with that. But if you project the map of the world showing the proportion of doctors in the region, that is what the world looks like. Africa almost disappears. And that is one of the things that we are faced with. Now, what do we do? Is it all doom and gloom for us? I want to show the following slide again, if you can project it. Yes. That slide shows, if you go up on the left axis, is health performance. On the horizontal one is the cost of healthcare. It shows what countries are spending and how much are they performing in terms of health. South Africa is that colored red there, meaning that all the countries above and to the left are spending lesser money in health. I'm not talking about the health budget. I'm talking about the total money spent in health within that particular country. It shows that all the countries to the... This thing was not done for people with small ears like myself. I do really have small ears and I'm struggling. Yes, it shows that all the countries to the left and above South Africa are spending lesser money in health than us, but with better outcomes. It shows at the extreme end, the very extreme end, at the end of the world, US, that the system used in the USA, which we are unfortunately trying to mimic, is such that United States is spending more money on health than any country in the world. But by all means, are they not the best performers? All the countries there, which you see, mostly in Europe and in other parts of the world, have got very little money spent on health, but with better health outcomes. Unfortunately, the South African system is mimicking the United States system. That is why the World Organization in their 208 reports, identified 3 trends that undermine the improvement of health outcomes globally, not in one country. And they identified those 3 trends as number one, hospital centrism, a situation where you don't do anything to the healthcare of the nation, but wait for everybody in the hospital with the belief that you have got all the equipment and all the money and all the expertise to deal with the problem. That is called hospital centrism. The second one is fragmentation in approach. South Africans know a lot about fragmentation. I don't have to lecture you. You live for more than 50 years with fragmentation of services. The third one is defined as uncontrolled commercialism, which undermines the principles of health as a public good. I know very well that I'm speaking to people mostly in the business fraternity. This might become very sensitive to them, but it is a fact. When commercialism in health becomes uncontrolled, it undermines the principle of health as a public good, and that's where the battle starts. Meaning that we are not necessarily saying there shouldn't be no commercialism in health, but it must not be uncontrolled. And that is our assertion. I want to show the following sets of maps, which are very important. If you don't understand much about NHI, please try to forget the others and understand these maps. These are from the World Organization, which shows what is meant national health accounts. That means what money is spent on health and in what way. And it's divided into 3. The blue is what is called mandatory prepayment. That's where a system of NHI falls in. That's where health budgets comes in. In other words, health that is paid for before the person is sick, in whatever way, but in such a way that it is mandatory. In other words, you have got no choice as a citizen. That money is paid long before you are sick. That is the blue. The red is voluntary prepayment. It's things like health insurance and medical aid schemes, as we use them in South Africa, is the red one. Is voluntary prepayment, because nobody forces you, for instance, to join a medical aid scheme or a health insurance. The last one is out-of-pocket payment, commonly called cash. You seek, you produce cash, just like you go to a shop to buy any commodity. Now it shows how countries are performing. If you look at the first 20 countries there, they are developed countries mostly in Europe. They've got a bigger blue, portion that is blue, meaning that there's a lot of mandatory prepayment, meaning that developed countries are moving towards paying for health before somebody is sick, but not in a voluntary prepayment way, not in a medical aid way as we're doing. The second group of countries, the 4 in the middle, are developing countries. The last 2 countries, we are unable to classify them. I don't know what to call them, because I don't know exactly how to describe them. But you can see that they differ from the others. The first one is my beloved country, South Africa, which relies a lot on the red portion. That means on voluntary prepayment for its citizens. And the last one is the US, of course. We are even worse than them when it comes to that. And that's why that first graph that shows that we're spending a lot of money without any performance, it fits in very well with that, with this one. The graph that follows is that we want to move in that direction. We want to be like the developed world and make sure that there is mandatory prepayment for health, meaning the blue portion must be increased. If you check the developing countries, the one doesn't have a red there is Cuba. But all the other countries in Europe are trying to do what Cuba is doing, regardless of how you describe their government. And the last graph, we want to be like that. Of course, we'll never be like Cuba. It's just a dream. But it's very important to dream on, because then you won't achieve anything if you don't dream. But we want South Africa to eliminate these issues of out-of-pocket and mandatory prepayment. Now, people are saying this can only happen, this issue can only happen in rich countries. How true is that? The second set of graphs show Africa. Can you move on? Which is very unfortunate. Move on, please. If you look at that map, these are African countries. You actually see what Africa is doing, moving away from the rest of the world. telling citizens that they are on their own. And if you check on that map, we are not doing well as South Africa. And Namibia, those red, what you call the columns there, the tall red columns, the first one is Namibia, the second one is South Africa. If you look at Angola there, it is number 1 and is doing very, very well. Out of these 43 African countries, South Africa ranks number 27 in terms of mandatory prepayment. Most of what we do in there is voluntary prepayment, which I say needs to be eliminated. The last country there is Sierra Leone, where almost everything is cash for the citizens. Now, we want to introduce the system of NHI because we believe we must equalize society, because NHI rests on 7 principles. The first one is the right to access to health, which is not just a principle, but in South Africa is Section 27 of the Constitution, which says everybody has a right to have access to health, and that the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. And thirdly, that no one may be refused emergency medical treatment, obviously because they are not able to pay. That's the first principle, is the right of access to health. So when people get involved in the debates of NHI, they must know also that it's a constitutional matter. The second principle is social solidarity, which of course, if you don't agree with, you'll never agree with us on health as a public good. The third principle is equity. And the third principle, yes, is equity. The fourth one, appropriateness. 5, effectiveness. 6, efficiency. And 7, affordability. These are the principles on which NHI will rest. Now, I want to finish my talk with firstly, a quotation from the Director General of the World Health Organization, Dr. Margaret Chan, when she was addressing a conference on NHI in Mexico 3 weeks ago on the 2nd of April, 2012. Her presentation was entitled, "More Countries Move Towards Universal Health Coverage." It's because the common name for NHI and other mandatory prepayments, the World Organization calls them commonly universal coverage. She said, and I open quotes, "This world will never become a fair place all by itself. Fairness, especially in matters of health, comes only when equity is an explicit policy objective. Universal coverage is a clear pursuit of equity and social justice. Universal coverage is also a powerful equalizer." I close quote. The second quotation from Dr. Margaret Chan, I open quote, "Moving towards universal coverage is never easy, but every country at every level of development and with any level of resources can take immediate and sustainable steps in the direction of universal coverage." Close quotes. When we officially issued the green paper on NHI, I said there are 2 preconditions under which NHI will survive in South Africa. The first precondition is that the public health sector has to drastically improve the quality of care, has to drastically improve. It has to be completely overhauled. The second precondition, I said the pricing in private health care has to be regulated in line with the constitution of the country. And hence I was proposing a statutory pricing commission to be established. Now, when we talk about piloting of NHI, we're talking about actually meeting the first precondition to improve the quality of care in the public health care system. In fact, I said it's not just improving it, it must be completely overhauled. And that's what we're going to be doing in the next 5 years, starting this year in the 10 pilot districts, which I'm going to visit and spend 3 days in each of them, talking about this, how to meet this precondition. And so in the next 5 years, we'll be doing that until we cover the 52 districts in South Africa. Then we'll move on Meaning we're not going to go to citizens and say start contributing for NHI immediately now without making sure that the precondition on quality of healthcare services has actually been met. Thank you. Do I sit here?